So let's get started. We are recording this meeting. Yes. So thank you everybody for joining us today. This is SEVA VentRounds Express, and we're going to do it live from CHEST 2022 conference. Today is October 17, 2022. And we have a couple of images. Well, actually, the three images come from Twitter, and we're going to analyze all of the waveforms as we speak. So the disclosures is I will discuss particulars of ventilator modes. There's no endorsement of any particular mode, manufacturer, or company. Whatever we say, it's our opinion, and it does not represent the Cleveland Clinic. I'm Eduardo Mireles. You can see there my conflicts of interest, and Rob, I don't see him joining yet, but in case he joins, those are his conflicts of interest. But remember, this is a recorded session, so keep your microphone muted. And I may call upon members of the audience to comment, but the best thing is just use the chat function. I'm monitoring it, and I do apologize for the noise from the trucks back there if that's impeding your audio. So usual SEVA VentRounds, we're starting now with a little bit of key knowledge, and I just want to point out to the team we're going to be talking today about synchrony. And so what is trigger is essentially the start of mechanical inspiration, and it can be done either by the patient, meaning effort, or by the machine, meaning the rate that you have set on the ventilator. And then cycle is the end of mechanical inspiration, and it can be, again, by the patient, and usually the end of when the machine cycles the breath based on the patient is either based on flow, or if you have in an EMG signal from the EDI catheter in NAVA, or the machine, meaning it's the inspiratory time you set on the ventilator. The second key message is when we're looking at these waveforms, we have to recognize what is the reference signal. And so the patient is the reference signal. So if you have a electrical activity of the diaphragm from a catheter, that is the reference signal. If you don't have that, then it's the muscle pressure. So for example, from an esophageal catheter, that would be the reference. And in our case, when we are looking at waveforms, the majority of the time we don't have any of those two. And we're looking for features that tell us that there's PMOS, or pressure from the patient. And so what you're looking for is the presence of deflections on the waveforms, usually the pressure or the flow waveform. So that's the basic concepts that you need to keep in mind as we're talking today. And so the first VentRound image that we're going to do today is this one that started circulating in Twitter in the last days. And so I'll ask you to write in the chat what do you think is the tag for this mode based on what you're seeing. So this is a GE care station from what I can see on the screen, and you can see that it's in another language. So that's the beauty about Twitter. We can get images from everywhere. So you have the airway pressure, you have the flow. So this is flow over here, and down here you have the volume waveform. And so you can see those three waveforms and try to figure out what's the tag for this mode. And put it in the chat. I'll take a look at it to see how it comes. And again, this is a courtesy of Ben Posters, who posted these waveforms. So let's see if anybody wants to tell us what they think is the tag. So what tag means is what is the actual mode of mechanical ventilation. Give you a couple of seconds. All right, I see it's going to be challenging for me to see the tag. Oh, there you go. Somebody put it in. Thank you. So Ryan wrote a couple of team members already came down recognizing this as volume control. So absolutely, this is volume control. And we know that because the flow is controlled. So you can see the breath, how the flow is actually triggered by the, so it's constant. But then there's this irregularity at the end of the of the waveform, which is atypical. But regardless, at the beginning of the flow, there is definitely its control. Then you see the breath sequence, and at least on this waveform that you're seeing here, we only see the breaths apparently triggered by the machine. So meaning the machine is triggering each one of these breaths based that I don't see any evidence of PMOS triggering the breath. And actually, if you see the beginning of the pressure waveform, it looks pretty, it looks consistent with somebody that is being triggered on volume control and that there's no PMOS. However, you can see the mode tag that was entered down here is SIMB volume control. So that tells us that this mode is indeed actually IMB, and it's type 1. Type 1 means that each one of the breaths that you are seeing right now are based on the rate that you set, and they will happen regardless if you want or not the rate to occur. So you actually can see that the rate is set at 16, and the breaths that are occurring are 16. And so both of them are definitely at the same rate. So, and that can happen with SIMB. If you set the rate too high, you will not be able to see spontaneous breaths. That may occur. And then this is called set point because both the flow was set, the tidal volume was set, and so all the characteristics of the breaths, both the spontaneous and the mandatory breaths, are both set by by you guys. So the next question is what type of load this patient has, and so it can be elastic or resistive, or there can be presence of PMOS that hides everything. So what I'm showing you right now is the presence of if you see how the flow starts and it goes right straight up, you're going to see that there is a rapid rise on the pressure, and that means that there is a resistive load most likely. So if I see just the first breath, it looks like there's a resistive load, and then the slope is consistent for compliance. So I would say that most likely this is resistive. During expiration, it's all PMOS, and we're going to talk about that in a second. So why do I say it's all PMOS? And the reason is normally an expiratory curve should decay exactly like that. And instead of that, you're seeing this sinusoidal waveform that is deformed by the presence of PMOS. So whenever there's PMOS, it will not move the same way that you want this exponential decay. So I think that this patient has increased resistance and increased PMOS during exhalation. Let me see, there's a comment here. I'm going to make it a little bit bigger. And so, excellent. So that's right, Tara. You recognize the absence of exponential decay. Then in terms of the PV discordance, let's start by the trigger. And every single one of these breaths is machine triggered. So it's triggered by the machine based on the rate that the operator set. But however, we see evidence of PMOS afterwards. So you can see the breath starts. This looks like a passive breath, rapid rise. The slope is consistent. And then there's this drop in pressure, a massive drop in pressure. Actually, you can see that the flow is still positive and it has not crossed zero. And so the pressure goes down and the flow goes up. And this is because this type of mode actually has something that changes the targeting. And the targeting stops being set point, and now the machine detects that there is presence of PMOS, and it will become dual, meaning that it changes from pressure to volume control, from volume to pressure control. So now the flow is responding to the patient demands, but still you can see how the pressure went all the way down, and then the patient eventually, in this one, the breath ends, and the patient can exhale now. And so In this type of breath, what I would call this is an early trigger, or also named in the literature as reverse trigger. And what that means is that the breath, the mechanical breath, started first, and then there is presence of a mandatory, a patient effort. So mandatory followed by patient in the same breath means that this is reverse trigger. During inspiration, the beginning is normal, but close to the end, you're going to see evidence of work shifting. Actually, the patient almost drops the pressure below baseline, but we would say that in general, it's normal. What you're seeing is part of the reverse trigger occurring. The cycle, again, because this is reverse trigger, you only call the first one, but there's evidence of an early cycle, and that's, you can see it here, rather than the flow decaying going rapidly down. Instead of that, it takes a while to decay, and so all this area that is missing is evidence of PMOS.
Okay, it's
So
on WebEx. Check your email. It's on WebEx.
I don't hear. Sorry, Rob. What are you saying? Rob, you were saying something?
I'm sorry. I two or three of us got mixed up. We were on Teams instead of WebEx.
Okay, all righty. So I'm gonna. Yeah, I don't know why that happened, but welcome back, Rob. And then finally, you have the. So again, even though this is an early cycle, you will not call it like that, because what is causing this is this reverse trigger or early trigger. And then finally, in expiration, as we talked, this is expiratory work. So this patient has, in summary, it's on volume control IMB type 1D, meaning that it's dual, because the flow changes in the press from volume control to pressure control with high resistance. And there's evidence of early trigger throughout every single one of the breaths that you see here. And there's evidence of expiratory work on this patient. So my suspicion is, or actions, that I would ask the team, what would you do to improve this patient? Enter in the chat. What would you change? So now you know this is volume control. The rate is set at 16. If you came to this patient, what would be your first action? Sorry, it's kind of chilly out here. Anybody would change anything? Well, normally, under this type of circumstance, my first suggestion for the team would be to drop the rate, to decrease the rate and see what happens, and see if this type of entrainment that is occurring, this breath and then the reverse trigger occurring over here, if it goes away. Other people may want to drop the rate. I probably would drop it all the way to 10, see if that continues to happen. If it still continues to happen, then this is usually a manifestation that the patient, in our view, that there may be toxicity from the sedatives, and the question has to be, well, do I need this patient to wake him up? Is the patient gonna tolerate that or not? And so that would be my input, is initially trying to drop the rate, decrease the sedation. If I was gonna change the mode, I probably would do pressure support initially to see what the patient is doing. But it's evident that the patient is getting very large tidal volumes. It must be a really tall individual. And the PEEP is relatively low with very high FiO2, so it's a little bit hard to know exactly what's the etiology of the disease on this patient for that large tidal volume with low PEEP and high FiO2, but definitely there's evidence of early trigger, IE, or AKA reverse trigger. Rob, comments?
No comments. Good analysis.
All righty. And I see the majority of the people put comments regarding dropping the rate. again, if you have questions or disagreements with this, please go ahead and put them on the chat. We're happy to go over this, or questions that you may have that you're like trying to wonder what's going on. Ryan, I see you. You're muted. Do you want to ask something? No. All right.
That was a mistake. But all volume control on the this GE ventilator is IMV DD, correct? Or is this the one that is not the spontaneous breaths? Well, there is no spontaneous breath, so it would be CMVD because it's not flow cycled.
Right.
It's time cycled.
Yeah.
If the patient starts to trigger or
That's
starts,
true.
yeah,
So it's
is that
different.
correct?
It's dual, but it's not IMV like servo is.
It's CMV. Okay.
So it remains BC IMB 1D for the mandatory breaths and S for the spontaneous breaths, meaning the spontaneous breaths are gonna occur in between, and they would just follow the level set of pressure support that you can see down here.
Right. But if we were in straight volume control, not SIMV,
right?
Okay.
It's
It would be
CMVD.
BC,
It's CMVD.
CMBD.
But
Yeah.
servo, it's IMV4DD.
Yeah, that's right.
Okay.
Any other comments? This is again, this is the implementation of dual targeting is very different across platforms. So there's platforms that do dual because they want to see the intensity of because they see a presence of PMOS, and there's other modes that do dual to limit the amount of pressure delivered or when the tidal volume has not been delivered. And then the algorithm to implement the dual in some of these will change across ventilators. So as we always say, you need to know what your ventilator does. And so this is just a rough guidance, and we continue to discover things that we didn't know that the ventilators would do.
Yeah, and just a one quick note. Every time that we mention dual on VentRounds, it's usually from volume control to pressure control. And that's only because we don't have any ventilators that do from pressure control to volume control, but there are some that do that.
Right. Thank you, Rob. Which ventilator has pressure to volume? Can you comment on that?
The most common one is the Draeger VN 500. You put it in volume control, and there's a setting called P max. So the volume will be delivered at the set rate, set inspiratory flow until inspiratory pressure hits the P max.
Yep.
Actually, that's volume control and pressure control as well. I'm talking about what was called volume assured pressure support. So I don't even know. Yeah, I think the Avia ventilator has it, but it starts off in pressure control, and if you don't hit your set target volume, then it switches into constant flow until the end of the set inspiratory time.
Excellent. Very good. All right, seeing no more questions, let's move to the next one. The next one, actually, it's fresh out of the Twitter oven. This was given to us from Haura in Beirut. And so, Haura, thank you very much for collaborating. I trimmed the image so that we could see the mode down here, not necessarily the settings, and then try to improve this as much as I could so that you could all see it. But it did generate a little bit of anxiety on my part as I was reading it to try to describe the problem. So I'm gonna show it for a second and see if people want to enter comments on what they think is going on this mode. I'll give you exactly 30 seconds to type in the little screen with your thumbs. By the way, it's really good to be back into live conferences. It's a positive statement in life. Reconnecting with a lot of people. And Rob, Rich sends his regards. I saw him today.
Chris Calais?
No, Rich Branson.
Okay, thanks.
No problem. All righty. All right, I see a couple of thoughts here. Let's hit it. Okay, so what is the tag? So in terms of the tag we have down here, you can see this, and there's some hints that I'm going to point at you. But the tag for BC Plus is PC CMB A. All right. So let's talk a little bit about that. So this is a common error in people because in BC Plus it says volume control, and so when they set the volume, people think that this is a volume control mode, and it is not. What you're controlling is the pressure, and here these are the classic waveforms that you can see of the flow not being controlled. Actually, there's nothing. You can see the pressure is relatively flat, and the flow has every single shape known in. I mean, they're chaotic, and so this is a pressure control mode. All the breaths are mandatory, and that means that there's a set inspiratory time, and you can see it down here. So you set an inspiratory time, and all of the breaths will end at that period of time. And there's a key finding here that tells you that this is a set inspiratory time. The patient is actually exhaling against the positive pressure that the ventilator is delivering. And so this is CMB. And then it's adaptive. And adaptive means that the ventilator is going to achieve the target that you set for it. So you set a target of 500 or whatever number you want, and it's going to move the pressure up or down after the breath is finished to achieve the volume that you want on the next breath. And so if you pay attention to this, and I'm going to amplify it for your eyes here, is you can see how in the first breath, the pressure is here. The second one is probably a little bit higher, not that much. In the next one, maybe a little bit, but this one, it starts, there's effort here, so that doesn't count. But look at the last one. The pressure is much higher because the tidal volume was not achieved on the other ones. So that's what adaptive stands for. So pressure control CMB-A, BC+. The load in this patient is a little bit tricky to see. So in inspiration, you don't see any flow at the beginning, and then in this one you see all PMOS. Instead of seeing the nice decay, you see a lot of effort. So this one that what you're seeing during inspiration is the presence of PMOS, so you cannot see the loads. And then during expiration, the patient is actually exhaling against the machine, the boom, and it has this, even though it decays exponentially, it has some irregularities that makes me think that this patient is having activation of the expiratory muscles, and it's hard for me to call it resistive or elastic. I'm going to call it PMOS just because of the way it's looking. So there's evidence of effort during inspiration and expiration. And so then is the type of patient ventilator discordance. And what you see here is a breath that seems to be triggered by the machine. So there was still expiratory flow, then it changes into a mandatory breath, but the patient actually doesn't get any flow. You can see this first breath, there is no entry of flow there. And that's why I think that the patient was bearing down. If you see this, that the patient, there was activation of the expiratory muscles, because with the very little pressure that the machine was delivering, it's not moving any flow, which tells me that this is a mandatory breath and that the patient is still actively exhaling. So this is the beginning of the breath, and then suddenly you see a spike on flow. And as that spike of flow occurs, and you can see it much more evidently on this one, there's rapid rise on the flow then. And this tells you that these two breaths are most likely an early trigger, meaning that it was triggered, the patient was still actively exhaling, and then the patient took a breath in, and there's actually evidence of PMOS throughout. You can see, and if you imagine the PMOS for this patient, it goes from around here all the way to here, and then the patient shifts from here to here, actually to here, to active exhalation. So this is another example of early trigger. Actually, you can see this one. This is a nicely triggered breath, you can see how there's a deflection on the pressure that the patient triggered that breath. You can see the flow rises nicely, and there's evidence of effort. And in this breath, actually, the patient starts exhaling again earlier than the set I time. And so in this breath over here, it's a normal trigger, but there's evidence of an early cycle, which you can see on the other ones, but that's part of the reverse trigger. And then I would say that this is an example of when VC plus is not a good mode in general, when there is high evidence of PMOS, and maybe that's the goal of the team that plays them on. But this is a patient that is having work shifting, meaning if you put here the table with the patient, the PMOS, and you put the P vent, sorry, there's a beer truck going behind us with music. They don't pedal fast enough. All right. So as the PMOS increases, the amount of P vent goes down, and that's what's happening here. There's very little support from the ventilator, and so forth. And then there's evidence of expiratory work. And so what you see here is, in summary, PCC-MBA with evidence of effort during inspiration and expiration, with evidence of an early trigger, work shifting in this mode, early cycle in one of the breaths that occurs here, and then evidence of expiratory work. So the question for the group is, what would you do for this patient? How would you improve this? And you can put it on the chat. Next VentRounds, I'm going to do it from one of those pedaling beer events. So what I hear is, first, all the breaths initially were like the third one, so I decreased the I time. Then I got this image. Yeah, so I mean, the patient is reverse triggering, and so probably, yeah, excellent, Hara. So Hara decreased the respiratory rate, and that's probably my first move whenever I see early trigger, is to decrease it and see if it continues. In what we have seen with early trigger, there's different phenotypes that have been described, but I would say that there's two major types of what you call reverse trigger. One, in which there is entrainment of the rate between the patient's rate and the ventilator rate, and when you decrease the ventilator rate, the patient takes over. And then there's another one in which actually the patient has repeated, even if you put them at very low rate, they have like this reflex in which they trigger another breath when you do that. So just be aware that that may occur. There's a good question here. Is pressure control better for multiple triggering? Great question. Actually, we recently wrote a paper in which we ponder exactly about that there's different modes, and in different modes you may see multiple triggering, but the effect is not going to be the same. So if you were on volume control, the side effect of multiple triggering is double dosage tidal volume. If you do it on pressure in PRBC or pressure control, what you're going to have is not double dosage of tidal volume, but you will be exposed to eccentric contractions of the diaphragm, because many of these patients are going to have what you see here, attempt to exhale during inspiration. And so the diaphragm may be in a disadvantageous position, although nothing has been proven about diaphragm injury from that. That's one of the theories. So yes, and then well, and you bring a great question here. Is how talks about sedation, and she says, well, the patient was not sedated anymore, and it may be. We have seen these transitions from early trigger that occur as you stop the sedation, they may come and have more of that, but as they start waking up, this goes away. So there's, in our experience, some relationship, although there's no book on that. And then there's a comment by Rob saying, why not use pressure support? Most of the synchrony problems institute to mandatory breaths. Absolutely. That's a great question. That could be an alternative, is that if the patient is at a level of support that you can back off from having more control. So the less control you have, the less synchrony issues you may have. So great point, Rob. And there may be other modes that if the patient is having periods of apnea, then as Ryan puts there may be intermittent mandatory ventilation strategies that may help you. It could be type 1, type 2 may help you, or even type 3 IMV. There's several modes that can help with that. Excellent. Very good. All right, the last one for today is from Ariel. He put this on Twitter too this morning or last night. And so I thought that it would be a good example of exactly what we're talking here with this double triggering. And so I'm just on the sake of time, I'm gonna read this one. And so what is the tag? And immediately, sorry, the tag on this mode, just from watching what we have here, is pressure. It seems to be the I time is not set, and you can see two different, even though it double triggers, the second one has a very short inspiratory time, and the first one has a long inspiratory time. So this makes me think that this is actually pressure control, because we're controlling the pressure. The flow is very different between them. But it's CSB, meaning all breaths are continuous and they are spontaneous. And they're triggered by the patient and cycled by the patient. And then its set point is pressure support. So we set the inspiratory pressure, so it would be S. So what's the load during inspiration? The only thing I see is PMOS. And during expiration, on this one that looks to be passive, majority of it, and this one, it's less than 1 second to get back to baseline. So I would say that the load is absolutely elastic on this patient. And there's other features that we're going to talk about that look like this is a high elastic load on this patient. So let's talk about that. So if we see the trigger is absolutely normal. I mean, the patient is, you can see a very tiny decrease on the pressure, and the system pressurizes really fast. And so you can rapidly see this is normal, a normal trigger. You have a pattern that is called multiple triggering, but it's not any of these that you see here. So it's not a problem with the trigger. It's just a pattern that has multiple causes. Inspiration is normal, meaning that I don't see major work shifting, although evidently the patient is doing effort because there's no exponential decay. But we would say that in general terms, the ventilator is doing work on the patient. The cycle on this situation looks like an early cycle. Why do we say that? Is this the system pressurizes, there's some amount of effort from the patient, and then the flow decreases rapidly. But there is still evidence of PMOS, and we think that this is evidence of PMOS because even though the ventilator cycled because the variable, and actually here Ariel put the end inspiration variable was put relatively high, that creates an early cycle on the patients that have very high elastic load. So they drop rapidly, and then they may still be having PMOS, and so they trigger the next breath. And so this is a type of early cycle, and it's physician or actually clinician induced. And then there's no evidence of work during expiration. Rob points out very clearly two major issues that occur here. Two. The first one is that the respiratory rate is very high. Actually, I forgot to show you. You look at this. This is the early cycle, very nicely shown. How the patient was still doing effort, and it didn't reach threshold to trigger the next breath. So very high elastance, and the system, the patient just didn't reach enough to trigger another one. So again, early cycle, and this would be adjusted by adjusting the end inspiration. But sorry for deviating, but you can see the rate is 48, and that's false, completely false. This is because it's counting these two breaths as one, as two different breaths when it's actually one. And the second error that you see here is this tidal volume that you see at 47, which is counting this breath over here, not this breath over here. So because it's going very fast, the patient exhales and then gets the next breath, and it's just displaying you a very tiny breath. So you could potentially make the error of assuming that this patient is breathing very fast and that the patient is getting tiny tidal breaths. And actually, you can see it here. This is 500 milliliters. So let's assume that this is around 400. And you can see that the first part of the breath, it gets around 400 of tidal volume. And the next one gets that miserable 40. You can see it there. And so this discrepancy may lead you to make mistakes at the bedside by thinking that this is true and that this is true. All righty. There you go. What do you do for this? You fix it. And you fix it by changing this end inspiratory cycle threshold. And I usually drop it all the way to 0 in patients that have very high elastance, because that will allow a longer pressurization time and decrease some of the work of breathing that they have. All righty. Comments, Rob?
No, this is a great example.
Yeah, this is exciting. Thank you for putting that up. Really a good example of how one setting can sabotage your whole existence. Yeah, and that's another one, Ariel. Thank you for pointing that out. I've seen this happen, that there's patients that will that this will not go away even if you go to 0 PMOS, and I think that that has to do. And now that we have better images of the activation of the diaphragm, sometimes we are taught to believe that the activation of the diaphragm is a nice sinusoidal pattern, but in reality, sometimes it can have different shapes, and it may continue to activate the diaphragm longer than what you usually would do. And so in these patients with very high elastic load, it's an issue. So perhaps in patients that continue to do that and that they still have these errors, you could potentially use systems like pressure control. So you set the I time at the measured I time that the patient needs, although, and you do that just to get rid of those double, your multiple trigger and the desynchronous comes with that. Yeah, NAVA is another one, although I would say, and this is another one of the items that we put in that editorial, is that NAVA, if I ask what is the desynchrony, the patient-ventilator interaction, the most common reported patient-ventilator desynchrony, or pattern that is reported in NAVA, what do you think it is? All of these that are here, what it is? Yeah, but which one is the most frequent, Rob? Of all of these ones over here, which one? Well, actually, it's not even here. So the most common pattern that you're gonna see is multiple trigger, or actually double trigger. In the trials, is the most common one that occurs on NAVA, and the reason is because of the cycling threshold is set at 70% of peak, and the patient may activate again afterwards. So that happens often enough that this is the most common desynchronous scene, and that has actually impact and relevance on how you when you're assessing modes. For example, if you're using the synchrony index, you may say, oh, the asynchrony index is elevated in NAVA, but it's all driven by the presence of this double trigger or multiple trigger, and in multiple trigger in this patient is not abnormal. it's just a manifestation of how the diaphragm was activating. So really interesting. Any other comments?
Eduardo, if I remember very well, this patient first initiated the inspiration with the diaphragm and right after followed with the upper chest.
Yeah, that's likely this type of neuromechanical uncoupling and the synchrony of the respiratory muscles occurs on patients that have these very high elastic loads, because the muscle that is strongest and the dynamics of the chest wall may be affected. So you may see that type of desynchrony of how they activate the muscles. It can also happen, and this is another type of desynchrony that has been described, in which actually you may read it as an early trigger. You may read it as an early cycle, but the trigger actually of the breath was the relaxation of the expiratory muscles. So the patient relaxes the expiratory muscles, then takes a breath in, and so they trigger the breath and then activate the diaphragm. And so that may give you this by model or by looking image on the triggering, causing issues with the ventilator synchrony. So really, really interesting. All right.
What that tells us is, as sophisticated as our technology is, we're still a long ways from a perfect ventilator.
Oh yeah, I mean, absolutely, Rob. The challenge of synchrony, and we tend to simplify the diaphragm to a very simple muscle that has a very monotonous behavior. And I would say that that's far from true. And we actually most of the time think about respiratory muscles and think about the diaphragm, but PMOS includes a series of muscles and interactions that with the chest wall at the same time that need to be accounted for. All right, well, live from CHEST 2022. Thank you very much, everybody, for your time and logging in. We'll put this on YouTube as we usually do, and thank you very much. Have a great day.